slowly getting better, her range is getting better, but then when you look at the, what?
And then she codes.
Yeah, then she codes. So, but when you look at the time difference between, you know, one reading to the next reading and the level of change, the trending, and that little time difference, we learned that even though it's in the normal range, it is going the wrong direction. It fooled us at first.
Well, and this is one of the things that comes up a lot in medicine, that, you know, you define normal ranges, and just because something's in the normal range, you know, doesn't mean it's normal. If you get a blood gas on someone and they have a normal PO2 of 80, but they're on 100% oxygen, that's really, really abnormal, because their PO2 should be, you know, 200 to 300. So it's something that comes up a lot, that, you know, normal isn't really normal. You have to consider everything within the clinical context. And so, yeah, so unfortunately, I guess we have an example of this, but, you know, this is why it's really important, you know, not only to look at it, but to understand the trend. And, you know, that's something that, you know, unfortunately comes up with asthma a lot, where, you know, people, if you don't understand what's going on, look like they're getting better, but they're not, they're actually getting worse. They're getting a lot worse. Any questions about that? Okay. And then this is showing a severe attack, and it just kind of the extreme of the values that were before then. So the CO2's going super high, the respiratory rate's going down, and as you pointed out, you know, cardiac arrest comes next. So these are the people where you do have to consider intubating them for asthma. Time to get moving. The asthmatic who looks tired and has a sharp fin is headed for respiratory arrest. Unfortunately, that is true. So you were asking about the head injury. So this is, again, not our protocol, but this is in Alameda County. So carbon dioxide dilates the cerebral blood vessels, increases blood flow, and therefore increases ICP. So, and people have gone back and forth on this over the years. The thought was if you increase their ventilatory rate, then the blood vessels get smaller, and then the ICP goes down. The flip side to that is if you do too much, then you're decreasing cerebral perfusion, which is not good in someone with a head injury. So I think we've gone to, I think people that have been practicing a while have gone to work. We were aggressively hyperventilating these people, where we said, whoa, 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 don't hyperventilate them, just, you know, try to keep them on the lower end of that 35 to 45.
So I had a patient that, this was a number of years ago, but was a hanging, and we got pulses back, but her end tidal was like 100. It was through the roof, and we couldn't get it down. And so we did that the whole way into the hospital, trying to figure out, okay, should I hyperventilate? Should I try and get the number down? Should we just do normal? And we finally, it didn't really change that much. And she ended up herniating a few days later. She lived a few days, but that was why. And so I talked to the doctors, and they're, well, you probably shouldn't, you know, we didn't really hyperventilate, but we did increase a little bit to try and manage it, but it was really challenging.
Well, it's hard when you get those people that have those toxic brain injuries or hangings. You know, often by the time you get there, you're not going to fix the problem. So this is the protocol they have, and I guess their value is 30 to 35. So they try to keep people with significant head injuries in the 30 to 35 range. Again, on a protocol here, you know, it's something to think about. Again, the end tidal CO2 isn't the same as the PCO2 that you would get in a blood gas, which is, I think, where most of these studies are based. But I think it's a concept we're thinking about, but not what we do here. So again, titration is not hyperventilation. You know, we're not hyperventilating like we used to. Basically, you're trying to keep them at sort of the lower end of the normal PCO2. So you don't want the PCO2 to be 100, so the ICP gets too high. You don't want it to be 20, because then the cerebral perfusion pressure goes down. Any questions about that?
Just out of curiosity, what are they basing their head injured patients on? A Glasgow with a certain injury, or how does that?
You know, I don't know. I haven't looked at their protocols in probably 10 years. But the guy that wrote this lecture is a fountain of knowledge, and I can give you his email and you can ask him. Because really, he's a smart guy. He's nice. He shared the lecture, and I'm sure he can answer that better than I can.
I'll go to the county website and look it up.
Yeah, I can give you his email too. He's a nice guy. So capnography, end tidal CO2, and cardiac arrest. So this is kind of where I think we first started seeing capnography. So it tells you about the cardiac output. It tells you the tubes in the right place, which are things we care about. Sorry, there's a lot of animations here. So increasing cardiac in CO2 during CPR can be an early indication of return to spontaneous circulation, which we talked about. There's some argument about using CO2 to determine prognosis in people in cardiac arrest. There's been some studies looking, I don't think it's the initial CO2, but I think it's after like 5 or 10 minutes of CPR. So if you're resuscitating someone for 10 minutes and their end tidal CO2 is less than 10, there's some studies that suggest that that's someone who's unlikely to survive. Whereas if you're resuscitating them and they're 10 minutes later the CO2 is 30, then that's someone that is likely to survive. I know some people are sort of taking this further than others, and some people are using that to say, well, then you should just stop the resuscitation. We're definitely not there in this county. But it's something to think about, and it's something that people are actively studying. And in a few years, we may see this, added as part of the, CPR policies.
I actually think it'll be added sooner rather than later.
Okay, maybe
now with
you know better than I do.
CPR,
No.
we're, we're calling in for non-ROS patients more often than we're transporting them to you. And so this is a piece that absolutely should be reported to the base physician for your termination orders.
Yeah. No, I agree with that. I think, it's useful information to have. And, one of the big things in CPR research, who was around back in 2000 when they changed ACLS? Yeah, do you remember why they used amiodarone? Because that was when they did that big switch, they took away that whole song and dance about the lidocaine, procainamide, and they switched to amiodarone. Did anyone actually read why they did that?
Is it amiodarone and wasn't it vasopressin? It was just a trial drug that the drug companies wanted to try, so they threw it out there in the protocol.
Well, so there's some argument about it, but the argument the Heart Association used, which I found really surprising, was that there was no evidence for any of the drugs we were using in CPR.
Yeah, it was all.
There, you had lidocaine, procainamide, mag sulfate, and there was no evidence that any of them were helpful. And we were doing all these things, and they're like, you know what? There's no evidence. There's a study suggesting amiodarone might be better, and there was a lot of controversy about that because it was sponsored by the drug companies and things like that. And I feel like this has changed a lot in the last 10 or 15 years, because it's 2015 now. But it's just interesting to see that we went from this area where we were doing all these things with absolutely no evidence. Similar things have been said about spinal immobilization and things like that, where we're doing all these things and we have no evidence to support what we're doing. And now, we're starting to get a lot more, first in hospital, now we're getting a lot more pre-hospital information. And we're actually looking at things that we thought would make sense and being, well, the evidence doesn't really support that. Maybe we should be doing things differently. So yeah, I think it's a really interesting time because we are seeing a lot of changes. Because we're now starting to get that information and saying, there's no evidence that epinephrine works in cardiac arrest. Is there evidence CPR works? Probably. No one's done the trial, but there's been some people arguing, well, there's no randomized control trial for CPR. So you can take it as far as you want to, and some people kind of take it to the ridiculous level. But I think it's a really interesting time right now in medicine because different than the last 100 years, we're actually starting to base a lot more things on facts and randomized trials and things that can be reproduced instead of just what people thought would be a good idea and people thought would be working. And now ACLS is a lot simpler. Any questions about that? No? So again, in verification of the proper tube placement, he really likes it, no waveform, no tube. And again, I would argue not normal waveform should make you think there's no tube. You can still get a waveform with an improperly placed tube, but it shouldn't look like a normal waveform. So core concepts. So what's the characteristic shape of a capnogram for a COPD patient? Yeah, it depends how severe they are, right? Because it could be a trick question. Right now they're asymptomatic, they look normal. So describe how the severity of an asthma attack using capnography. What level should you maintain a head injured patient CO2 at? Again, not in this county. And what are 2 ways capnography can assist during CPR? So we kind of answered that, right? So troubleshooting. So one of the issues if you're using the BVM and you're using that mainstream or if you're using the side stream is you can get an inadequate seal. So if air is escaping around the mask during the BVM respiration, you're going to get these kind of funny patterns. And you want to make sure that it's not an obstruction that's causing it, just that the seal isn't right. So you can try readjusting the seal. But you see, in the beginning you get a normal waveform, and then you get kind of this funny one where it drops off. And that's probably at the end of expiration, you're losing the seal. Obstruction, so if you have an ET tube that's obstructed, it's either obstructed by substance like blood or mucus, or there's a kink in there, you're going to get this erratic waveform. You should be able to look at that right away and say that's not a normal waveform. And then sort of troubleshoot to see what might be causing it. There's something called rebreathing, or this is something we talked about with auto-PEEP, where the end tidal CO2 at the end of expiration should kind of stop, go to 0, and then start over again. This is an example where someone's exhaling and then they're breathing in before they really finished exhaling. So the line doesn't go all the way down to the bottom. And again, it can be because of the vent, or it can be someone that's breathing and they're just exhaling and they have to breathe in again. Again, this is someone with asthma, COPD. Are you ready for a quiz?
Sure.
All right. What happens if they don't pass the quiz? Okay.
Whole day.
You'll take the bagels away.
No more lemon poppy.
All right. Hypoventilation, right? You guys just scream it out. Awesome.
Rebreathing.
Rebreathing.
You guys are so good. Yeah, I want to check that too, right? Look at that, you guys. You're going to be awesome.
It was in the field.
Yeah, so bronchospasm, asthma, COPD.
Is that normal?
These guys are so smart. All right, any questions? You guys feel free to compliment me on the awesome lecture I wrote. So any questions at all, comments?
For CHF, the waveform, I mean, there was an example up there, but just like there's that shark fin typical for the asthma that we talked about.
It's not going to be like the asthma because it's not bronchospasm. If you're actually interested in this, there's a website called capnography.com. And it's just capnography.com, and they have examples. They have hundreds of different waveforms in there. They show what the different changes are. They have some animations. I can send you an article if you want to share it with people. It's sort of the overview of capnography, and it talks about different things like different waveforms, different examples, and kind of presents an argument about why we should be using it and using it more routinely.
The CHF patients have a tendency to have a prolonged expiratory, so you kind of see it drag on a little bit. It's like, it's not that cut off.
Yeah, but I'll send you the article, and the article is, you can read it in half an hour or so, and it gives you a good background. But it's something that's changing, and I think it's exciting. When I was a paramedic, we didn't do CPAP, we didn't have capnography. When I was in Alameda, we didn't have 12 leads or STEMI centers. So the stuff is changing in, I think, really good ways, and it's a sort of an exciting part to be part of that.
Did you use paddles for shocking?
We did.
Good, see?
Yeah, and they worked.
Yes.
But that's another issue.
The EMTs, just to help even the medics, can carry around side streams in their pockets, and then, when they're putting the patients on the monitor, you throw the side stream at your medic, and
Pockets are always having this stuff.
They should-
carry around for a minute.
I know.
Yeah, they should glue, they should have packages of side stream or mainstream and CPR masks.
Yeah.
So when you apply it, you stick it on at the same time.
Yeah.
I mean, you guys can get really cool fanny packs.
We have them.
No.
Just,
How surprising.
yeah.
All right, thank you.
Thank you so much.
Thank you.
You know what? Don't worry, I'm going to send you something.
Sure.